It's my pleasure to join you, and I also have to thank the organizers and Dan and Tony for inviting me to participate. And I have no disclosures except to say that I recently retired from Kaiser Permanente, and thus I have no funding, and thus no conflicts in my funding. And to Rob's point, there are probably some other biases out of passion and care and history that are brought here, but I have to say that it has been an incredible exciting thrill to be in a room over a couple of days with a group of people with the depth of thought and care applied to this this area that is in a difficult times, it offers hope actually to going forward. And I heard a call to over the last few. Well, first of all, our charge for this time was to actually have a couple of slides about barriers and policies. But in all honesty, most of the things, if not all of them, that I had prepared has been discussed in the last couple of days. And I heard a call for a charge to pivot to implementation. And I thought maybe the reason Dan asked me to come was because I have a lot of experience in implementation and execution in a large multidisciplinary medical group. And so I thought I would just share with you for a couple of minutes some of that experience by using a couple of general points which will embed some policy implications. And then after that, actually to use a couple of examples of how we went through implementing a couple of things in this system. But I have to first provide some context, which was when it was the last century when we started this, which is to say that the environment around us was a little bit different. There was less evidence available, although that has grown over time. We used, and then where, Kaiser Permanente in Northern California, which is a large group and has all of the forces at play as in the greater world, except that it's a combined system of delivery of systems and also paying for systems. So Rob's list of all of those positions, those Ps that he had, I wore all of those hats, being responsible both as a clinician and as an executive for implementing healthcare delivery systems. So at some point in the mid-90s, in late 90s, our executive director gave me a call and said, this CAM stuff, we can't get our hand around it. Patients want this stuff. We don't know what to do. Please come help. And so I'll use a couple of examples. But first I would caution that one note is that while we have all agreed that patients should have access to individualized and comprehensive and integrated multimodal self-care, as a foundation for where we go and where we should end up, I might just pivot that a little bit to say that actually people should have individualized, comprehensive, and multimodal health care policies for themselves, and that we can, if we want to end up with our chronic pain patients understanding this is a part of their life forever, really this is true for all of us, with or without chronic pain, and if we use that as a starting point, as we have personal relationships with our patients, we're able to more honestly communicate that and effectively help them move into understanding where they are given their history, exposures, et cetera. So I would offer that as something that implies, as was already said by Rob, everything I was going to say somebody's already said, which is that it does really call for a public health campaign where we would bring to the public with well-known and very influential folks, and that actually drives behavior in the general population much more than randomized clinical trials, in fact. But in order to bring something to a large system, what we tried to do, what I tried to do, I'll just be very quick now, I'll use two examples. I'll use acupuncture and mind-body medicine. When I brought the evidence base for acupuncture to our group, that didn't really work. So, and I can go through long stories here, but what really did work was when we stopped and stepped back and showed them utilization data that we mined, and if we gave a brief acupuncture program, which was just 4 to 6 treatments, and we showed all utilization for 6 months prior to that and all utilization for 6 months past that, the utilization in primary care went down by over a third. It went down in every single department except for chronic pain, appropriately, because they would get a diagnosis and move on to that program. That actually is what got our group to say, yes, go forward. We will take some of those resources. Remember, a single pie means that if I'm adding any clinicians, I'm taking them from somewhere else. That's a big burden to carry as you go through and trying to implement something. I'll just say briefly, to implement it, we had to walk through, given time, everything that you would do in every other system. So credentials and privileging, how do you create operational integration, how do you use charting, and how we then used that to help bring our, what we called ancillary providers and adjunctive treatments into our system in a single medical record system, where that opened the door for communication between clinicians, which then they had to be trained to do, and it was everything you learned in kindergarten. Behavior is appropriate with respect, et cetera, et cetera. And so we actually built programs, and I built trifolds, and we went out and had programs with primary care and specialty care, meeting different clinicians and talking with each other, and learning how to actually execute the integration. Thanks, Rob. The other thing I would say is, this is echoing something Eric said earlier. We did not actually try to build another universe, because that's what you would have to do. So we built our systems thinking with the end in mind. If we were going to have these programs in place for the long term, where do they live operationally? So mind-body medicine programs they wound up coming into our very mature patient education programs, and as well as psych and some behavioral medicine modules and our primary care modules. We built them into where they lived, and that worked. So I'll just stop by saying that for educational, if we shift then to educational policy implications, they really, wearing my UME, GME, and CME hats, there's a place in each of those arenas where you can build in the expectations for accreditation bodies, for various ways to actually build it into the expectations of the outcomes. And in addition to the institutionalization, it was mentioned earlier, Joint Commission now has a way for us to use getting institutions to now say, this is my expectation. And you can go beyond that using that policy principle into the institutionalization of these programs. And I will stop there.
Terrific. Thank you, Dr. Goldberg.